Okay. Right, so T1, and that's for MSK derangement or mechanical processes that we're looking at. So, you know, if we're looking at the cartilage, if we're looking at ligaments, tendons, things like that, we would typically use proton density. However, when we're looking for tumor or infection and we're going to give contrast, we have a little different tact. We have to do T1s and T2 fat sats, okay? So we get a little less signal, a fraction less signal, but we get more contrast, okay? So when we give contrast, a little bit more contrast in our images, okay? The reason for that is a couple of things. Firstly, we don't want to do proton density before contrast and then do T1 after contrast and say, well, did that lesion enhance before contrast or not? We don't know, okay? So we have to do T1 weighted imaging before contrast. We have to do T1 weighted imaging before contrast, so as we can directly compare it after contrast and see whether it did enhance before versus afterwards, okay? The same thing with T2 fat sat, we prefer not to do proton density fat sat because we get a little bit more contrast, okay? That's not hard and fast rule, but it's mainly the T1, we always need to do a T1 pre-contrast so as we can compare it post-contrast, okay? So that's that. Some departments, I mentioned right at the start of this module that some departments do different protocols. So some departments may do a mixture. You'll find that some departments do a mixture of T1 and proton density, okay? If I was to ask you, there's a tumor and infection in this patient presents with a tumor infection, what 4 sequences would you do before contrast? If you told me you would do a T2 fat sat in axial and sagittal and a T1 in axial and sagittal, in this case, that would be perfect, okay? And then you give contrast and do the T1 afterwards, but yeah, that's not the question. But if you told me that you would do a T2 fat sat and you would do a proton density fat sat in 2 planes, then that would be incorrect, okay? Does everyone understand that? Because both of those four sequences would show pathology. We'd have no sequences to show anatomy, okay? So if you, and likewise, if you said 4 sequences before contrast, we'll do 2 T1s and we'll do 2 proton density weighted sequences, then that would be incorrect as well because we wouldn't have any pathological weighted sequences. Okay, so it's important that you get a mixture of anatomy and pathology. Either T1, you need a T1 pre-contrast, but you can do proton density as well, and T2 fat sat or proton density fat sat. Okay, you don't do T2 fat sat and proton density fat sat because they essentially show you the same thing. Then we give contrast. We do a T1 fat sat post-contrast. We do the fat sat so as we don't get a signal from fat because we know that when we do T1, we get a signal fat's bright. If the contrast is bright, then the contrast can get mistaken for the fat or it can get hidden in the fat signal, okay? So simple, let's null the signal from fat and then the contrast stands out, okay? So if something's bright, it's more likely to be contrast than anything else, okay? Okay, there's a list of MSK infections and tumours that we can have. Obviously, it would be, you don't need to know all those, you don't even, that's just an example of what sort of pathology there is in the body and in the MSK. Obviously, there's a lot of different types of tumours. They're commonly found in different places. They commonly have different imaging characteristics before and after contrast and on the different weightings, which is why we want to differentiate an erythemal source bone cyst from a fibrosarcoma. Okay, so we do 5 different scans, or we do 7 different scans plus contrast to show that the tumour that we're looking at is that and not that. Okay. An example of a tumour is that I've just picked one tumour for a little case study, and that's a Ewing sarcoma. It's a metastatic tumour found primarily in the bone and soft tissue. Most cases occur in adolescence between 10 and 20 years, and most often they're found in the bones of the trunk, pelvis, scapula, and ribs. Okay, and in this case, we have a patient with a nasty lesion in their scapula. Okay, you can see that the lesion's bright it's heterogeneous. Okay, and it's bright on T2 fat sat. Okay, so that means we don't know what the fat content is. We know it's got fluid in it. Okay, we don't know about the tumour. We can guess where the tumour is. We can have a pretty good guess at where the tumour is, but we don't know exactly. Okay, T1 axial is very good to show the surroundings. Okay, we see mass effect, we see involvement. We might see involvement of the tumour in the normal bone or the normal muscle. And then, of course, they're the sort of characteristics of the weighting, image weighting. The main thing is with these is that we need to give contrast to distinguish from the edema, okay, the reactive edema, the edema that the body sets up versus the tumour. Okay, and you can see that the tumour is quite extensive out here. We know this is a T1. We know edema is dark. So anything that's bright is likely not edema, it's likely tumour. Okay, does that make sense to everyone? Okay, so, and then of course we do the different images, we do the different imaging planes depending on the location of that tumour. Okay, so we can go axial, we can go sagittal, and we can go coronal. You can see that, or you could imagine that if you have a tumour in the scapula, the most informative planes are going to be an axial, so you can cut that tumour axially, or cut that along the axis. Along the axis, and sagittally. Okay, that body of the scapula, you can cut it, and you see more information. If you do it coronally, you're scanning along the length of that scapula, and it's not as informative. Okay. But that's something, I think that's something that you just learn when you start scanning. We always try and do 3 planes post-contrast, okay, because contrast is going to give us the most information with these tumours, so we always try and do 3 planes post-contrast. Usually you could argue 2 planes, T1 and T2 fat sat pre, and then 3 planes post. Okay, but again, it depends on the department. I can't tell you that's the best way to do shoulders and chuck out the rest, because there's a radiologist at Knox that might stand up and say, absolutely not, you do this because of this. So it's departmental protocol. Moving down to the hand, so we've discussed Ewing sarcoma or a tumour. Here's an example of inflammatory changes. Okay, so you can see on T1, we know T1's the anatomy. You can see the bony erosions. Okay, if you have a good look at those hands, you can see bony erosions. You can see reactive processes in those fingers, nasty fingers. Okay, in the T2, we see pathology. So we see those reaction processes are bright. All right, so any bright signal around the joints and around that pathology indicates, or likely indicates, pathology, in this case, inflammatory changes. We do contrast, and we see that there's, we see the enhancement in active inflammatory changes. Okay, because active inflammatory changes, or most inflammatory changes, will have an increased blood supply. We've tagged the blood with contrast, if we see an increased blood supply, then we know it's contrast. Okay. We also do wrist fractures, so and hip fractures. So you've been told for the last 3 years MRI is not as good as CT to show bones. Okay, so why would you do an MRI on a bone when CT is much better? Well, actually, in some cases, MRI is better than CT to show subtle fractures of bones, because what happens when we have subtle fractures of bones, we have the body has a reactive process, sends in fluid. Okay, so if the body sends in fluid and we do a T2 weighted scan, guess what? The fluid's bright. Okay, so we don't necessarily see the changes in the tubercular pattern as we would in a CT or an X-ray. On a T2 weighted scan, we'll see a very bright line where the fluid has been deposited or situated in a fracture. Okay, and on a T2 FATSAT and on a T1, we're going to see the actual fracture if it's possible, if it's big enough. Okay, but the most sensitive scan when we're doing a fracture is T2 FATSAT. And then it's most sensitive, not to the fracture itself, but to the body's reaction to that fracture, sending edema. Okay, and of course we've got a wrist fracture, and we've got triangular fibrocartilage. So that's a common area in the wrist that is disrupted in fractures or in trauma. Okay, and also attrition, also wear and tear. All right, so that we'll do common areas. Exactly the same, we'll see, we're going to discuss the meniscus in the knee shortly, but it's a similar sort of thing where if you see increased signal in that area, we've got fluid, and even on T1, the fibrocartilage should be hypointense. So if we see increased signal even on T1, we know that there's disruption there. Okay, we know that fibrocartilage is hypointense because it's got no hydrogen. Okay, it's not going to give us a signal, just like the cortex of the bone. Positioning scans of the shoulder is usually relative to the supraspinatus tendon. Certainly in mechanical damage, we want a baseline, and we want to see that supraspinatus tendon go all the way across the shoulder. Anatomical structures must be learned before they can be viewed and recognised on cross-sectional imaging. Hopefully you've done that now. Common acute pathologies are generally bright on T2 or proton density FATSAT due to edema. Proton density or T1 images are usually used to view anatomical structures in and around the shoulder. Proton density or T1, I think, whatever. Inflammatory and infective processes and tumours should involve IV contrast due to their increased vascularity. So any tumour, any infection, any pathology that has increased vascularity should have contrast if the patient's able, okay, for reasons that I've identified there. Okay, any other questions? Anything before we move on to imaging of the knee? Everyone's good with that? Okie dokie. You have discussion boards, you have my email, so if there's any problems, please reach out and touch somebody. Okay, share. All right, can everyone see the knee? See my knee?
Yep, we can see it.
Great, great. Thank you. Okay, so the same sort of thing, we're going to concentrate on a little bit different aspects of the knee, but the same sort of tasks. So we're going to look at osseous, articular, and soft tissue structures in the knee. Okay. We've got a list of osseous structures there that, and of course we've got the PowerPoints that you need to study or revise. You don't need to study because you've studied them 3 times already. Articular anatomy, so you've got the ligaments, the tendons, the cartilage, the structures around it, the synovial fluid, and you've got soft tissue anatomy, so tendons and ligaments. Okay, so now we're going to just talk about the signal within all these structures. So we're going to show that the bone cortex has low signal. Okay, why does it have low signal? If we're in a lecture, I wouldn't go on until someone answered me, but because we're on Zoom, no one answers me. I can do a little dance. So the bone cortex is dark on all weightings. Anyone want to guess why? No.
Does it have to do with hydrogen?
It certainly does.
Okay, just a guess. But would there not be a lot of hydrogen compared to something like the muscle?
Exactly. Perfect. Exactly. What about if we compare it to bone marrow? Why is on T1, why is bone cortex dark and bone marrow would be bright?
Does it have a higher water content?
Yes, but don't forget on T1, water's dark. Nearly.
Sorry, fat content, is that?
Yes.
Yeah, there we go.
Perfect. So bone marrow has a lot of fat in it. Okay. So we know that fat's bright on T1, and that's why bone marrow is bright on T1. We know that fat's got a high signal. Okay, so it's high in proton density, and it's low on T2 fat sat because we've saturated out the fat. Okay, cartilage is variable. We'll talk about that a little bit later on, but there's 4 layers of cartilage. Some research material says 4, some says 3, but it depends on the references, and it depends on the exact terminology that you use to describe cartilage. But in this case, it's variable. So there's the different layers of cartilage have different appearances. Okay, tendons have low, exactly what we said about the bone cortex. Tendons have low because they're made up of very few hydrogen protons. Okay, ligaments are low, meniscus is low, exactly the same reason on all weightings. Okay, muscle is intermediate, fairly low on T2 fat sats. Okay, and we'll see, and you can imagine what that would look like. Joint effusion, so iso intense, iso, and of course on T2, joint effusion is going to be bright. Okay, proton density, it depends on the weighting, and we're going to talk about that in the next couple. Why have I got hemorrhage? I'll give you either A, I couldn't be bothered looking it up, or B, it's variable as well. I should have put variable really, shouldn't I? And the answer is B, because hemorrhage, the intensity of hemorrhage depends on how old it is. Okay, so we know, and it also depends on the type of sequence. We know that new bleeds, the ferritin in the blood causes dephasing, okay, in gradient echo, so it's going to be dark. Okay, as the age of the blood, or as the blood evolves over certain the next couple of days or weeks, the composition changes, so the signal changes. Okay, we're not going to go into how the signal changes, but it depends on the type of sequence that we're doing and the age of the bleed. Okay, depending on whether it's hypo, hyper, or iso intense on the different weightings. Okay, and that's also the case, even more so in the brain when we're imaging the brain. Positioning. Okay, so foot and ankle positioning. Basically, we're looking at a sagittal, then we're looking at an coronal, and we're looking at an axial. Okay, as if the patient was in the anatomical position. I've got an itchy nose. So patient supine, we use a foot and ankle coil or a small flex coil. Okay, you would have seen the difference in those things in clinical, hopefully, in the first semester. The foot and ankle coil is a lot more stable. you get a lot better imaging in the foot and ankle coil. The flex coil is good enough if you can hold your patient still, okay? And it's positioned perpendicular, parallel with the Z gradient, okay? Because we get our spins in the transverse plane, we don't want to position our flex coil parallel with that transverse plane, okay? Of course, the patient has to be comfortable and padded. The ankle flexed 90 degrees, but don't make it uncomfortable, okay? We need to have the patient comfortable. If they've got a strain when we're doing their foot and ankle, if they've got a strain to hold it there, they're not going to stay still, okay? 2.5 to 3 millimeter slice thickness, because the structures that we're looking at aren't huge, they're not tiny, okay? And of course, the thinner we go, we've discussed, the thinner we go with our slices, the less signal to noise, okay? Hip imaging, we go above the hip to below the lesser trochanter. Coronals, we go in front to behind the hip joint, and we make sure we get the insertion on these greater trochanter. And of course, sagittal, we cover the hip joint as well. Notice the positioning of the sagittal. With this one, most radiologists prefer we don't angle along the neck of the femur, okay? Because we're actually looking at the joint and the head of femur and all the muscles around it. They like to go perpendicular or orthogonal to the patient, okay? And then, so that's sagittal and that's coronal, okay? So coronal from the front to the back of that hip. The exception to that is when we're doing a fractured NOF, okay? If we're doing a fractured NOF, then we're going to go along the length of the plane of that neck of femur, okay? We're not going to go, and we're going to go sagittal. We're not going to go orthogonal, okay? That's the exception. With the knee, you can imagine patient supine, knee uses the knee coil, okay? Slight flexion. External rotation is not important anymore. We like to keep the patients just with a slight flexion, so as we keep those ligaments lax and we don't stretch any that might give abnormal signals. As far as external rotation, in the early days of MRI, they used to have external rotation because, like the shoulder, we always angle along the ACL, okay, line. So we always like to see the length of that ACL in one or as minimal number of pictures as we can. Okay, so if you can see there that if the patient's externally rotated their knee, then that ACL is going to go vertical, and if we do orthogonal imaging, we're going to go along the plane of that ACL. Okay, and that's when in the early days we couldn't angle the images, they had to be straight. So now I like to keep that external rotation on to help you remember to angle your images, okay? So if we either do external rotation on the foot and angle them straight along the plane of the ACL, or we can make them more comfortable. If we make them more comfortable and they can be in a position, and then we angle the plane 15 to 30 degrees oblique along the ACL, okay? You can do either one. Front to back, unless there's something specific, if they're looking for a Baker's cyst or something in the back of that knee, then we do from the front of the patella to the back of the condyles, okay? And then we're going to get most of or all of the ligaments and the attachments. We're not going to get a couple of these muscles, but we usually don't need to cover those muscles at the back, the gastrocnemius insertions. Okay, sartorius. So we can go from the front of the patella to the back of the condyles. Okay, and there's our imaging. So we go along that ACL ligament. Okay, so now we'll turn to the weightings and we can see which one's which. A little quiz, and you don't just think about it by to yourself. We've got a cyst here, okay, and we've got a proton density or a T1. Which one's which? Okay, so if you can think, if anyone wants to say, great, go for it. Otherwise, just think about which one's the proton density and which one's the T1. Okay.
Hey Richard, I'll give it a shot. So because the cyst is bright on the left-hand side, usually it would be bright on a proton density, so that's how we can figure it out.
Perfect, exactly. Okay, so water's bright on a proton density. So this one is more likely to be a proton density than B, A or B, whatever. Okay, exactly, perfect. But you can see that the information that you're going to get on both these images is very similar. Okay, it's for anatomy. So you can see the structures. Maybe this little lesion in the bone has a bit more contrast in it, so you can see it a bit better on the T1. Okay, proton densities are really dependent on the TR and the TE that they use. Okay, when I was first learning about MR, when I was first learning about MR, I saw a MSK and the fluid was bright, and then I'd see the brain, PD, and the fluid's dark. And I got terribly confused. And then I had to go home and have a little cry because I thought I knew everything. But now I realise, well, no, it's the TR and the TE and the times of relaxation that determines whether the fluid's bright or dark, okay? And most of the parameters that we use in MSK for proton density, the fluid's bright. I didn't go home and cry, actually. I stayed at work and cried. And now, of course, we've got T1 fat sat. Okay, we know that's not T2 because, in fact, I'll prove it. There you go. We know that's not T2 because the fluid in that cyst is dark. Okay. What's this? What's that little dot just outside the foot? Anyone have any ideas?
Is that a marker?
Hoi! Yes, top of the class. I've got Mars bar here, but it's a shame I can't give it to you over Zoom.
I don't like Mars bars anyway, so it's all right.
Oh, the other thing was I already ate it.
Oh, okay.
Excellent, well done. Okay, so that's a marker. So if patient's got a lump, okay, they put on a little vitamin E dot, okay, and then that dot, if we scan around that dot, we know that's where the lump is, okay, exactly like a... Did you say you don't like Mars bars?
Yes, I did.
Oh my gosh.
And I've got a sore tooth today anyway, so
oh yeah,
I'm trying to avoid sweets, but I don't like Mars bars anyway. I prefer Snickers.
Okay.
Each to our own, I guess.
You're wrong, but okay, no problems. Each to their own. Great. Okay, so there's our marker. It's vitamin E capsule or just like a little fluid capsule that marks that little lesion there. Excellent. Okay, so we've got internal derangement as a pathology. So that's like mechanical injury to the knee. Okay, so an example might be anterior cruciate tear, posterior cruciate tear, meniscal abnormalities, to look at cartilage degeneration and to look at subchondral bone trauma. Okay, so obviously bone trauma under the joint, under the cartilage, and we'll see that. Anterior cruciate ligaments, sagittal, ACL, we want to see it in its entirety. Not only is that just a standard image for the sagittal sequence, but ACL is more commonly ruptured than anything else, or more important to visualize than anything else. So we want to see it in its entirety. Okay, got the imaging there. So parallel with the line of the intercondylar roof, and we will see it on the axial. And we also need to note the individual fibers at the tibial attachment sites in a normal ACL. Okay. Obviously, coronal and axial, we won't see it in its entirety, but we will see it, and we will be able to sort of get a cross-section of those ligaments of the ACL on the other images. Okay, so we can see it's hypo-intense on all these images. Okay, and we can see, again, when I was first learning MRI, I was told that that's a map of Australia. Okay, and the ACL lines along the eastern seaboard, or aligns parallel with the eastern seaboard. Okay, and then of course the right ACL, so that's the left, the right ACL aligns along the other side, the western side. Okay, but again, you need to know your anatomy. I don't. So like the shoulder, changes in morphology or course and signal intensity are going to be the giveaways to pathology. Okay, complete tears in 3 planes, disruption of all fibers, and irregular wavy contour. So we know that there's a complete tear, and that one end is not joined to the other end, so we get a wavy contour. Okay, sagittal may appear depressed along the spine of the tibia, and coronal ACL will be indistinct within the condylar notch, so we won't be able to find it in the condylar notch. Okay, scar tissue can simulate normal ACL or show angular appearance. Okay, so if we look at if we're looking for acute tear, it's often difficult, or it can be difficult to contrast acute tear from scar tissue. Okay, increased proton density and T2 appearance. We know that, and we know that's caused by edematous fluid, not necessarily synovial fluid. Okay, so acute tears, acute and subacute, will have edematous fluid and possibly even blood. Okay, make sure we have to distinguish that from synovial fluid, which we know will always also be bright on a proton density and T2 appearance. There may be increased signal change in chronic injuries, not acute, chronic injuries due to synovial fluid. Okay, so we know it's there. Foci of mucinous or myxoid changes, partial voluming, we know that from CT, and suboptimal selection of sagittal imaging planes. So if we don't image a plane along the ACL, if we image it a little bit more, a little bit less, we're going to cut off a piece of the ACL. Okay, and we're going to, in that volume, we can get other substances around it, and they appear in a tear because they're going to increase or decrease the signal around it depending on what they are. False negatives, formation of scar tissue adherence. So scar tissues obviously can be in or around the ACL. Partial tears, it's important to distinguish full from partial tears. Residual fibers intact, that may give the appearance of a normal ACL. Okay, so there's our high-grade injury to the ACL. So we can see we don't have a continuity of that ACL. Okay, actually, I lied. That's the ACL there. That's the PCL. We don't have continuity of that ACL. Okay. We can see maybe proximal ACL, or the ACL attached on the tibial bone there, and it's hypo-intense. However, we lose that hypo-intense intense signal if we compare it to this one where we've got a hypo-intense signal, the course of the ACL. Okay, so that's a nice ACL fibre. Whereas here, we've lost that hypo-intense signal. We've probably got blood and fluid, and the ACL has been retracted. We don't see that hypo-intense signal, so it's likely to be certainly injured. If you can't see it at all, more likely to be completely torn. Okay, we see the T2, of course, if it's completely torn, if there's high-grade injury or often low-grade injury, we see fluid there. Okay, so sagittal T2 fat sat, we just get a whole collection of fluid where the ACL should be. We also see in the coronal T2, we also see what's called bone bruising. Okay, so you would have heard, I'm sure you would have heard or all heard that before. If you do a fat sat sequence where the water is bright, so either a T2 or a proton density, you're going to null the signal from fat. These little vessels, microhemorrhages, and trauma to the bone inside the bone, the subchondral bone, and the bone, and just the bone is going to cause edema and signal changes within the bone. Okay, so that's, of course, that's called bone bruising. Posterior ligament. So we've got sagittal, we see in its entirety, coronal seen on 1 or 2 images, and axial used to support findings. So we can imagine that axial through the ligament. Okay. Flexion is taut. Hyperextension is relaxed. That ligament in flexion, the PCL is taut. When we're hyperextending the knee, it's relaxed. Okay. Usually tears occur in mid-substance, less common at site of insertion or origin, so in the middle of the ligament, and T2 signal is increased in acute or subacute disruption due to hemorrhage or joint effusion. Exactly what we've just seen in the ACL. Okay. Normal PCL, lovely thick ligament. Okay. Lack of signal, we've followed that ligament across. We usually see it in 1 or 2 planes because it's usually in the same plane as the ACL. Okay, and you can see there, if I took that arrow away, you can see the PCL is a little bit thicker than the ACL. Okay, thicker caliber ligament. This isn't my best image, I'm afraid, and I apologize for it every time I present it because of the artifact. But if you can see around the artifact, you can see that that PCL is disrupted. Okay, so it's torn. You're going to get signal disruption where the tear is, and you're going to get discontinuity. Okay, so you're going to have a hypo-intense signal that's not joined. All right, and then you can imagine if we do an axial scan, we can see, and we sort of get an axial view of that ligament. Okay, so if it is joined, if there is small amount of signal in there, we have a look at our axial view to see exactly where that signal is. Okay, and of course we see the corona. I mentioned cartilage. So normal cartilage shows variable signal intensity on 3 weightings: superficial zone, transitional zone, and deep radiate zone, calcified cartilage or subchondral bone and subchondral bone. Okay, so normal cartilage, abnormal articular cartilage, generally decreased signal, but may be increased due to edema. I think I might show you the cartilage first. So there's our cartilage here. Okay, that's our normal cartilage along the tibial plateau, and we can see different layers there. Okay, and we can see the cartilage there. Again, different layers. We can see it hypo-intense best, and then we get a little bit of signal in a different layer along the synovium. Okay, so generally decreased signal thickness, but may be increased due to edema. We get good anatomical detail and high contrast on T1 weighted images between the cartilage and the subchondral bone. Okay, so between the cartilage and the subchondral bone, we get good differentiation. Okay, the T2 fat sat, we get good differentiation between the bone and the synovial fluid. I'm sorry, between the cartilage and the synovial fluid. Okay, so you can have your cake and eat it too. Arthrogram effect when joint effusion is possible. Are you after? Oh, you have to knock. I haven't seen her. So joint effusion. So we can do scans, and I'll show you scans in the next couple of slides of joint effusion. In fact, let's jump ahead. There's hyperintense signal, and we get more of an arthrogram effect because of the, which is, we know arthrogram effect is more increased signal in the synovial fluid. Okay, probably not the best example, but because you could imagine, maybe you could imagine if that synovial fluid was even brighter. Okay, you would imagine if we did a T1 and we injected it with intra-joint contrast, I can't remember, arthrogram contrast, that synovial fluid would be bright. Okay, we can do certain T2 weighted sequences where we can get that signal without having to give contrast. Okay, or at least attempt to get that bright signal, that bright arthrogram effect, without injecting contrast into the joint. So where are we? I'm going back. I think I jumped ahead a couple of slides. So arthrogram effect with joint effusion. And we discussed those. So there's our normal cartilage. There's a little cartilage here, or a little area where the cartilage has worn off. Okay, so you could imagine there's nice cartilage along this plateau, and then if you get decreased cartilage or injury to the cartilage is worn off. Okay, and you've got no cartilage in that little notch, and you've got subchondral bone changes. Okay, so underneath the cartilage, underneath the bone surface, we have some bone changes. Okay, and of course that's a proton density, so it shows the changes, maybe the changes in the tubercular pattern and the anatomy very well. Sagittal PD fat sat shows the pathology very well. So it shows, of course, those changes going to attract fluid, okay, which is going to be bright on PD fat sat weighted imaging. The other thing we have too, we have fast imaging, we have gradient imaging that we've mentioned. We also have what's called bone mapping, okay? And bone mapping, what that does is it just shows you the magnetic susceptibility of areas. So we use it quite a bit in research. We do the areas with high magnetic susceptibility can be bright. Okay, we can use it, give it a color scale. And so bone mapping sequences are very common when we're looking at cartilage, and they show increased signal where there is bone lesion. You can see there's a bone lesion here, that little notch at the top of that arrow. Okay, so we can see this sequence here, the gradient sequence has shown the cartilage bright, and then we've just missed a little bit of cartilage as it goes across. Okay, so that shows that disrupted cartilage well. This shows the disrupted cartilage because we've got a lot of fluid there. and then on the T2 fast spin echo, and then the bone mapping shows the disruption to the cartilage in the sequence as increased signal or increased color in that sequence. So that's called a bone mapping sequence. And we usually do the bone mapping sequences to show cartilage. Okay. Okay, so we know the meniscus. We know the meniscus separates the femur from the tibial plateau, and it absorbs the shock. Okay, it's hypointense on all weightings due to be composed of fibrocartilage, so it's got no hydrogen. Okay, it's got no hydrogen. We discussed ad nauseum. If it's got no hydrogen, it's got no signal. Sagittal oblique and coronal images are most informative to show meniscus, and we'll show you that. Medially has sharp central margins, coronal triangular appearance. Artifacts may simulate tear. Okay, so we have to be careful to distinguish artifacts from tears. And we grade them. Okay, so we grade them. A 0 is no tear. A grade 1 is discrete foci, so a signal within the meniscus. A grade 2 is a linear tear, intrasubstance, so not extending to the surface. Grade 3 is a linear tear that is extending to the surface. Okay. And of course, meniscus may be blunted. We'll see examples. And we also have meniscal cysts. So there's our lovely meniscus, full of fibrocartilage, which absorbs the shock when we jump up and down. Okay. We can see it on sagittal, parasagittal. We can see it on T2 by the little triangles at the top of my little pointer. Okay, hypointense signal in those triangles. We see it in the axial around the edges of the bone. Okay, so that's a hypointense signal around the edges of that tibial plateau. So what do we see when it's disrupted? We see signal within the meniscus. Okay, so we have a tear here. We have a normal meniscus, the triangular appearance, and we have a tear in the middle of that, meniscus. Can you see that bright line? Okay, whereas we have a normal meniscus here. Sagittal, coronal imaging, we have a tear along this sagittal line in the meniscus, okay, whereas the image is a very small tear there, but the meniscus should be iso-intense and should be hypo-intense, okay. And of course, we have a grade 2 tear here. No, grade 3 tear here because that tear has extended to the surface. Okay. We're getting there. We're nearly finished, so bear with. Bucket handle tears. So we've got the bucket handle. Okay. And we've got, I beg your pardon, sorry, the bucket. And we've got the bucket handle. Okay, so you can see how that tear has just split that cartilage into two along longitudinal to the cartilage. Okay, so it's split it. It's no longer to be able to absorb that shock, and you've got a stretch or you've got a space in the middle where that bone end is exposed probably to the femur bone end. Okay, so you're going to start osteoarthritis. What does it look like on imaging? It looks like increased signal, okay, and increased signal. So we've lost the cartilage here. We've got the body's reaction, which is descending fluid, and thus we have an increased signal in the T2 fat-SAT images. Okay. We also have increased signal in the T1 and the proton density weighted images, where that meniscus is separated. Okay, and you can see that on the axial as well. Collateral ligaments. This is probably a good example of what I was saying before about the planes. We can see those collateral ligaments are hypointense, like all ligaments. Okay, and you could imagine the best planes to image these would be coronal, because they're deep, okay, or they're shaped along the side of the more along the side of the knee, and axial. Okay, so if you did axial through the knee, you'd interrogate these, or you'd be able to see them in cross section. Oh, excuse me. Okay, so if you saw them in cross section, you saw a little signal there in the coronal, then you'd go and look at the axials and you'd be able to see that signal in cross section. Okay, one plane that wouldn't be overly useful is sagittal, because if you did sagittal scans along there, you're not going to really see, you might get it in one, maybe two planes, and you don't know whether that signal is going to be, if you see an increased signal, is that partial voluming, or is that actual signal in the ligament? Okay, so it's always good to really think about, obviously we don't want to do all weightings in all planes, so think about department protocols, but also think about what you're scanning and think, okay, what plane is going to get the best images for this patient, for this structure? Okay, and there's our collateral ligament with an MCL tear. Okay, as we've said, hopefully you've picked up through these lecture series, any disruption of these ligaments is hyperintense on T2, and you see the changes in the hypointense signal on T1. Okay, so if it's discontinued, if it's if you've got a complete tear, you're going to see retraction of that ligament. Okay. Iliotibial band is another structure that we see well on MRI, and disruption of the iliotibial band. And a Baker's or popliteal cyst, same thing. Okay, so swelling in the popliteal space behind the knee joint, in particular arises between the medial head of the gastrocnemius muscle and the semimembranosus muscle. So there it is there. Okay, it's a cyst, so it's going to be bright on T2. And we've got the medial head of the gastrocnemius muscle, and we've got the semimembranosus muscle. And we've got a whopping great cyst in the middle. Okay, so I mentioned as well, usually we don't extend our slices back past the condyles of the knee. Of course, if you saw this, then you would want to do coronals all the way through the knee. Okay, we've got to always think about what we're doing for our patient. We never scan a patient. What's the patient for? A knee. All right, we'll just go and do a knee. We have to always think about what we're doing and why we're doing this scan of the knee. Okay, so there's our popliteal cyst on sagittal. There's a couple of artifacts. Okay, so magic angle affects molecules that lie at 54 degrees to the Z direction, or to B0, the main magnetic field. Okay, increases the T2 time of these molecules. So at longer TE times, these molecules have already decayed, so artifact is negligible. Okay, so therefore we only see sequences on short TE. We only see this effect, this magic angle effect, on T1 and proton density imaging. Okay, we don't see it on T2 imaging because these structures have already dephased. Okay, we've already got the TE time. Basically any structures where that ligament can be angled at 54 degrees to B0. And there we have signal in there. Okay. We see it on the proton density. We have to go and make sure it's not there on the T2 because we're not going to get a magic angle artifact on a T2 weighted image. Flow. Okay, we should know by now that flow occurs on a phase direction. So we know that that phase in this sequence is AP. Okay, and we get that pulsation artifact. Caused by movement of molecules in the field of view, occurs in the phase direction, pre-saturation band, so we null the signal from those pulses, and we can swap the phase and the frequency direction. We can also use what's called flow compensation, which is changing the gradients along the length of that, along the line of that flow or in the direction of the flow. So it cancels it out, okay? It's worse on 3T because we know 3T, we get more signal from everything. Partial voluming, decrease slice thickness. We know that when we decrease slice thickness, we have to, we get less signal to noise, okay? So we have to sort that out as well with all our other factors. We know magnetic susceptibility. When they've got metal there, it's magnetic susceptibility in this case caused by metal, anything that causes a change in the magnetic field. The magnetic field in this area is not homogeneous, okay? So we're not going to get any signal there. We've discussed that, hopefully. And we've discussed chemical shift, okay? I think I've shown you this slide where the bandwidth. With chemical shift, we have to increase the bandwidth. Okay, so there's more hertz per pixel. So when we have 440 hertz difference, that's more likely to be in one pixel than multiple pixels if the bandwidth was very small. Okay. And that's MRI of the knee in a nutshell. Any questions? Anything, anyone? Did I go too fast, too slow? Is there anything anyone wants to talk about? No, everyone knows everything. Good. Because I know everything.